Welcome, everyone, to the 7th episode of the podcast series, Kris Vanhaecht on Quality. Today, a somewhat strange podcast, as this podcast will be hosted by two AI colleagues, and it is based on a health quality British Columbia seminar. The full webinar can be found at the HQBC website, but here you find a summary I made with my friends of JellyPod. We're tackling some big questions about the evolution of patient safety, lessons, levers, and those stubborn gaps. So glad you could make it, and let's dive into this deeper. So let me give the floor to my two hosts for today.
Hey, always great to be here, Kris, and thank you for the invitation to present the summary, and this is definitely a topic that matters.
Yes, also for me an interesting challenge to try to provide your listeners a summary of what you and your colleagues discussed.
The HQBC seminar was fascinating. Just hearing Christina Krause gather minds like you, Kris Vanhaecht, but also your mentor Peter Lachman, together with Ross Baker and Ulfat Shaikh in one virtual room? Honestly, that's a global powerhouse lineup right there. Good choice by Christina and her great team in BC, Canada.
Absolutely. Christina Krause opened the seminar with context, reminding us it's been 25 years since that To Err is Human report, and in Canada, the Ross Baker report, which really brought the world's attention to patient safety in the early 2000s. That is also the time that you started your academic career, Kris.
Yeah, right. And there's this sense, it's almost a frustration and a relief, that the field's both come a long way, and is still, well, a bit niche. Peter Lachman really hit that. We know the science now. We know what to do in many cases. Psychological safety, tools, culture. But it's how to get those smart, busy clinicians to do it as part of normal work. Implementation's the thing, right?
Exactly. And Peter's own story, having to tell parents that their child died due to a simple but fatal mix-up, really underscores why this work matters so much. Back then, the mistake was seen as negligence, not human factors. So we've gone from that old, blame-based approach to one grounded more and more in systems thinking.
Yeah, it's such a powerful shift, but not one that everyone's made. There was also talk in the seminar about the WHO's 2021 call to action on patient safety. That's helped push it up the political agenda. Different countries are making big strategies now, but there's still so much variation and, inertia in some corners.
And the seminar did something quite interesting, actually, starting with the panel's own stories. Ulfat Shaikh brought up a different angle. She's been working as a pediatrician, and she said the biggest losses come when talented clinicians aren't supported. Stress, burnout, people leaving, the personal impact is massive. But it's the system losing knowledge too, isn't it?
Totally. Not to drift too far, but Ross Baker also gave Canada's trajectory. He brought in IHI concepts like quality improvement and recounted, almost stumbling into safety as a specialty after the IHI forum with Barrick and Leap. It was all new as late as the 90s, which is a bit wild, honestly. Meanwhile, Kris Vanhaecht has seen the field grow from his PhD research on care pathways in Belgium over to Mango Moments and FlaQM, Flanders Quality Model, and where now he's also focused on One Health, bringing in environmental and animal health along with human health. So the global dimensions really stand out.
Yes, that broad lens is crucial. But at the heart, the persistent gap is, we know a lot, but it's still not as embedded into practice as it needs to be. There's excitement, but frustration, the key theme to carry forward, I think.
So, let's get into the hard part, turning those strategies into real change at the point of care. There was a recurring message from the panel. Context is everything. Don't just hand people protocols and expect miracles. Peter's Mozambique ward example really stuck with me. Locally adapting a tool, the track and trigger system, took an adult ward from 8 in 10 deaths a month to only 2 a year. That happened because they asked staff what would work in their actual context and translated the approach. That's massive.
It's such a telling example. And it shows why top-down mandates often flop, like that Matching Michigan story Peter mentioned in the UK. A program worked wonders in Michigan, but floundered in Britain because no one asked local ICUs what their unique problems were. It's an easy trap, isn't it? Assuming one size fits all will fix culture or workflow.
Yeah, and Kris Vanhaecht really emphasized that too. He shared that when he teaches medical students or runs research in Belgian hospitals, the why is often missing from safety interventions. If you don't explain the rationale, why use a safety checklist? Why redesign a process? People just go through the motions or ignore it. Highly skilled people need to understand purpose to engage. I mean, it's obvious when you say it, but it's so commonly missed. I also suggest that you listen to Kris's podcast on human error or the one on the history of quality. Both are accessible through Spotify. If you are interested in these topics, take the time to listen to the other podcasts in this series.
Absolutely. There's also this nuance where psychological safety comes in, also a topic of one of the other podcasts. Kris's new research is showing huge variations in psychological safety scores even within the same organization. So it's not just about structures or policies on paper, but whether people feel safe to speak up, adapt, innovate. I find that fascinating because it shifts the focus from prescribing solutions to genuinely listening first. That is also the experience Ross Baker is sharing, based on his experience in Canada on quality and patient safety. Ross is the father of patient safety research in Canada. My tip is to Google him and read his landmark paper from the early 2000s.
Exactly. So there's a clear call here. Before you plan a so-called improvement, pause and talk with frontline staff. What's their actual day-to-day challenge? What's stopping them from following a guideline, or what's making it unsafe? Only then co-design a solution. And actually, I wanted to get your take. How do you think organizations can really get that kind of authentic co-design going, with both clinicians and patients?
Ooh, good question, and not an easy one. I think it starts with creating those regular, non-judgmental forums, spaces where feedback isn't just solicited, but truly welcome and acted upon. It ties back to that psychological safety. And as Peter, Kris, Ulfat, and Ross kept highlighting, it's the micro level, those tiny systems of care where change lives or dies. If you don't listen at that level, you'll never sustain improvement.
Right. It's so tempting to focus on national policies or grand plans, but the proof is at the bedside. That is also Christina Krause's experience. And it's not only staff, families, patients, communities, they all have context. Layer that in, and yes, you might have some complexity, but you actually get solutions that last. Otherwise, you just keep rediscovering, oh wait, that didn't stick. I guess to summarize, the lesson is listen first, then design. It's so easy to forget.
And perhaps harder to do than to say, but utterly necessary. Let's keep this thread, because it feeds right into thinking about the workforce, co-production, and, really, what gives us hope for the future.
Yeah, and it's not just complaints, it's research-backed. Ulfat Shaikh was adamant. If clinicians are burnt out, patient care suffers. Her advice was so practical, even if she admitted it's something she's still learning herself. Put your own oxygen mask on first. Ask for help. Build support systems. There's no shame in looking after your own well-being as a safety measure.
Yes, it's a message we hear but rarely act on, don't we? And beyond that, there's a wave of hope building. More clinician-led improvement projects instead of initiatives cooked up in distant offices. Human-centered tech, used well, as Peter said, not as another burden, can genuinely support safety work. And embedding safety in medical education from the very start, as the experts put it, into the genome of healthcare workers, so it's not an afterthought. It just is how things are done.
Exactly, and I'll just jump in here with a quick real-life parallel. Back when I worked with a team learning QI tools during the pandemic, I wasn't the clinician, but facilitating that sense of mastery. It was clear. Once frontline folks felt they had the tools and the agency, they would step up, even when things felt downright impossible. Ross Baker brought this out as well, how that sense of agency can really change the temperature in a pressured environment. Smart, capable people want to own their improvement if they're trusted and supported.
That's such an important point. And Peter's perspective on patient and family co-production, he actually dislikes the idea of patients as products. He says no, safety is a service. It's clinical excellence plus compassion, engagement, treating people as people, not numbers. The future is about making patients and families genuine partners. They bring ideas, context, feedback that no checklist can capture.
It's a radical but necessary shift, especially after COVID, when families couldn't be in the room. New clinicians missed seeing just how fundamental families are to safe care. Training this generation to co-create with patients, not dictate, is crucial. And what gives us both hope, I think, is seeing those young professionals hungry to make systems better, asking big questions right from their first days. That's a big leap from where the movement began.
Absolutely. We're seeing energy and curiosity from younger clinicians, allied health, across the board. And as Ross said, it's not about working harder, but working smarter, using what we've learned to shift the paradigm. There's reason for optimism, even as challenges remain.
Couldn't agree more. And, well, that's probably the best note to wrap on. Hope, grounded in real-world progress, not just wishful thinking. Thanks for such a thoughtful chat. Truly enjoyed it.
Me too, and thanks to our listeners for being with us. These conversations don't end here, so do tune in next time as we keep exploring what it really means to make care safer, together. Goodbye to all. Take care.
Take care, and goodbye, everyone. See you next episode.
So thank you all for listening, and thanks to both hosts for explaining us what was discussed during the HQBC seminar. As mentioned before, the full conversation is available at their website. Thanks again to Ross, Ulfat, and Peter for joining me. A special thank you to my great friend Christina Krause and the whole team in Canada for making this happen. Talk to you all soon in a next episode of Kris Vanhaecht on